Welcome to Philosophy.
The Business of Benefits is your no BS, no sales guide to real solutions.
No gimmicks, just the truth about how to take control, transform your benefits, and care for your most valuable asset, your people.
If you're tired of the same old sales pitch and you're ready to rethink your benefits, this podcast is for you. The truth is out there. Are you ready to hear it? All right, everybody, you are in for a treat today because I told you when we started this new podcast, the whole idea was no BS, no frills, no sales, just the truth. And we have on today who I believe to be the biggest truth teller in the entire benefits industry. If you are in our industry, she's famous. You already know her. If you're an employer listening, you need to know her. Her name is Deb Alt, and she is the owner of Alt International Medical Management, also known as AIMM, AIMM. And I've had the pleasure of knowing Deb. She's one of the first people I met when I entered into this industry. And I remember, you guys know I'm super real. I was scared shitless of her, if I'm being honest. She terrified me. She was so bold, so blunt, and you'll hear it today. But she's so real, which is what I've always really connected with her over, because that's my philosophy when it comes to educating and progressing this movement of transparent healthcare. You have to have real conversations. You have to have tough conversations. And, you have to instill in employers, because employers are the only ones that can fix our broken healthcare system, one employer making one better decision at a time. You have to instill in employers the confidence and the courage and the inspiration to think just a little bit differently. And when you hear her speak today, I guarantee that you'll feel that way. So we cover a ton of topics. I'll admit we bounce around a little bit because I get excited when I talk to Nurse Deb and I'm kind of like, woo, squirrel. But we talk about what is medical management, right? What is the actual function of medical management, whether you're in a fully insured plan or a level funded or a custom self-funded health plan. From there, we share stories about literally, you'll hear the stories, but they are crazy. They're going to blow your mind. Literally life-saving stories by having a nurse concierge medical management built into our health plans. Guys, there's also ways to incentivize employees where they have no out-of-pocket costs for calling the nurse. There's a lot of different ways you can kind of integrate medical management. She'll talk us through those today. And then, like I said, you're going to get some inspiration. You're going to feel really good about thinking about your healthcare problem a little bit differently. The last thing I'll say is that Deb, interestingly enough, beyond just being a total pioneer for our industry, a bold, trailblazing, badass woman, she's actually the inspiration behind the documentary that we produced. It's not personal, it's just healthcare. So if you haven't seen the documentary yet, hit me up. I will send it to you. After you hear this episode, you will be a Deb Alt fan. If you're not, you just can't handle the truth. But for real, you'll love her. Follow her on her socials. Get a copy of the documentary and let me know what you think about this episode. Don't forget to share, like, subscribe. All right, everybody, we are back at the Business of Benefits. I'm your host, Chelsea Reikus, and today I have one of my industry favorites, Nurse Deb. If you are in the benefits industry, she's famous. You already know her. But Nurse Deb, thank you for being here today. This podcast is actually for employers. And while I'm sure you know many, there's probably a lot you don't know. So why don't you give the employers listening, HRs, CFOs, CEOs, a little background on who you are and your business AIMM?
Absolutely. Well, thank you so much for having me. My name is Deb Alt. I'm a registered nurse. I'm the president and founder of AIMM, and we're essentially a team of nurses and doctors that come alongside patients, usually telephonically, although now with some additional technology, and handhold them through the two most cumbersome ecosystems in the universe, the healthcare delivery system. So what care should I be getting? When should I be getting it? Where should I be going to get it? And the health plan system, oh my golly, how do I avoid bankrupting my family and my employer in that whole process?
Yeah, that was a really good explanation of it. And I know we're going to get really deep into medical management and kind of like the why behind it, where it fits. And, I'm actually really interested today too on your take on like how the carriers are doing it when they're consolidating all of it versus unbundled self-funded and some of those differences. Because I think I expect that a lot of the listeners listening to this podcast are interested in that journey from fully insured to self-funded. So I want to get there with you, but before we dive too much into insurance speak, I'm super curious on your ethos. So obviously I own Ethos Benefits. Ethos is the guiding principle, spirit of a community, person, organization. What kind of got you into this business, and what, drives you every day to make the difference you make?
Yeah. Well, I was born to be a nurse. My parents thought I was going to be a doctor, but nursing was the better venue for me.
Yeah.
But I had a traumatic experience, and there's a whole magazine article that talks about it. And, I'm a good night shift ER ICU nurse.
Okay.
Right. Love the technology, love the math and science, the lovey dovey, touchy feely stuff during day
What
shift.
do you
Not quite
mean?
so much my stuff, right? Not quite my thing. But I had this patient, and we should not have admitted him, but we admitted him. And long story short, it went horribly, horribly wrong.
Mm.
And I lost it. And my nurse manager at the time said to me, "Do you know how much money we would have lost if we would have transferred him?" And that was it.
Yeah.
I did not become a nurse for this. This is not right. And all of a sudden, that light bulb came on for me that healthcare is a business, and that a lot of people are going to focus on the business first and foremost and only on the business. And eventually, after I got over my major depressive episode related to that whole thing, I was like, I'm going to figure out how to take control of the money.
Okay.
Somebody with some morals and ethics, and somebody who has some empathy, and somebody who actually gives a hoot about people. See, aren't you proud of me? I didn't cuss.
No, so it's me. You're totally allowed to cuss. So I'm going to record the intro to your show a little bit later, but the intro is going to include the fact that you gave me the inspiration when I first started in this industry to not give a shit and be myself and be authentic, because you are so damn bold, so strong. So no, swear away. It is welcomed on my show at least.
Well,
How long ago, Nurse Deb, was this experience, the traumatic experience you had in the ER?
30 years ago.
Wow. And, unfortunately, I mean, it's a little pessimistic, but it's not like much has changed, has it?
We still have a lot of the same problems, but now we're chipping away at it at least.
100%.
And I think really in reality, the United States is at a turning point when it comes to healthcare and health insurance in particular, right? So that excites me.
Yeah. Let's talk about that. So I know what my opinions are on why you're saying that, but if employers are listening and maybe they're not as in the know as you and I, what do you think is sort of the driving force, or maybe the catalyst towards some of this transparency and change happening for employers right now?
Well, and the other part is I'm an employer myself,
Mm-hmm.
right? So I get what employers are up against.
Yeah.
And if you're making widgets every day, all day long, you don't feel like, and you certainly don't want to be in the healthcare business, but you are whether you want to be or not.
100%.
Right. If you look at your P&L, at least in my MBA program, they're like, you got to look at your P&L. And when you see your number one expense is people and your number two expense is benefits,
Mm-hmm.
You're in the healthcare business whether you want to be or not.
Yeah.
The problem is you want to focus on your core talent, your core business, and your HR people are probably telling you, retention and benefits and recruitment, and so-and-so's now on week 11 of FMLA, and, you're not understanding, you're not making the connection,
Mm-hmm.
right? Which I think I'm at an advantage because of being a nurse,
Right.
right? Your business doesn't go anywhere without your people.
100%.
So, but CEOs, CFOs, CHROs may not always be totally embracing that idea
Mm-hmm.
of we got to take really good care of our people. And part of it too is if a hospital is run by an administrator who's making millions, plural, of dollars in salary a year, then surely he or she is focused on that healthcare system doing the best healthcare they can, generating the best outcomes, right? So we're kind of trusting that the way we run our business, we want to make the best widget ever. So of course a hospital or health system
Right.
wants to have the best out. And in reality,
There's people at that hospital with the title revenue cycle management, folks. Like there are literally people at these hospitals that are employed. I go to conferences with them all the time and they don't love me and I understand why. But their job is to get more money from employers, quite literally. Yeah. So one more question for you before we kind of dive deeper into medical management and all of that. What do you feel like is maybe something that you believe that's a little controversial or something that you could say that could maybe wake employers up to realize, like, guess what? You do have power?
Is this my you can't handle the truth moment?
Ooh, I love it. Let's do it. Give it to me.
Oh my golly, there's so much. There's so much in that category. Here's the thing that makes me just want to smack employers sometimes, right? You don't get it that you are making the buying decision, and that buying decision has life and death consequences.
Correct. Yeah.
Right? So, I mean, anybody who wants it, I'd be happy to share a link to the life and death consequences stage presentation that I did. And it just came from this place of frustration. Like, you're letting your people be butchered, maimed, killed, and you're spending a ton of money to do it. And that is just so wrong. When are employers going to get pissed off enough to have the cojones to step away from the traditional, the status quo, the big carrier? I get it. Nobody ever got fired for hiring IBM. But guess what? I don't think that's going to hold true into the future.
No, and people are going to be sued for having Express Scripts and Aon. Sorry to name names, but...
Absolutely. And your employees are right now on the cusp of understanding we're ticked off at United Healthcare.
Yep.
Who hired United Healthcare?
Exactly.
It wasn't me as the employee.
100%. So you're absolutely right. I listened to a podcast today on the plane, Mark Cuban, Stacey Richter, Relentless Health Value. And it was literally a conversation about how much longer before employees start realizing that the employers are the ones that are unfortunately making these decisions. And that, and even though, I don't know if you saw, but like the Lewandowski Johnson & Johnson case, the recent ruling a couple days ago where the judge was basically saying that, damages.
You would have hit your out-of-pocket max anyway.
Yeah, which really, I mean, it
talk about a technicality.
No shit. And also like how like premium equivalents are derived from these PBMs and the excessive waste and abuse. So it's like, sure, it might be a little bit hard to prove, but everybody has suffered as a result.
That entire employer group has suffered.
All 140,000 employees or however
Correct.
Many. So
right.
You're right. We're very, very close, especially with like hospital transparency rules, the Consolidated Appropriations Act. You have the Patients Rising and all sorts of people that are so freaking fed up. And I feel like what people are experiencing is the message you've been saying for decades, or at least the decade that I've been in the industry. You were the first person to really aggressively get out there and be like, you guys, this is BS. There's a way to solve it. And I know how, like, listen. So I'm really excited for you in the sense that like, you've pioneered so much change for our industry and you've been such a great leader, which is one of the reasons I wanted to have you on the show. And I wanted to share a little story, if you're okay with it, about a client we had together. This was a couple years ago. And just to give everybody an idea, the employers listening on like, okay, so Nurse Deb told us what medical management is, but like, what is it actually, right? Like, what does it do? How does it work? How does it benefit me? So quick story, and then Nurse Deb, I'll let you take over onto the intricacies of it. But we had an owner actually of a local Orlando company, and he was getting a surgery. I don't know if you remember this specific case, Nurse Deb. He needed to get, I want to say it was a shoulder surgery. It was some orthopedic surgery. And he called us and he's like, I want to go see Dr. X. And this doctor has billboards and buildings named after him and all that shit. Well, long story short, we run this through Nurse Deb's analytics, through her data, through her program, because guess what? When you work with somebody like Nurse Deb, or Nurse Deb specifically, you actually get data, like quality metrics, not just what is this doctor's bedside manner online, but literally like what are the readmissions, the infections, like I'll let you speak to all that. But so long story short, he's adamant about going to this surgeon. Turns out the surgeon does not have a very good quality score in Nurse Deb's book. So literally this doctor had a couple medical malpractice lawsuits. One was wrong surgery, wrong patient, wrong surgery, wrong limb, and then right surgery, wrong limb. 3 open lawsuits, and my CEO of a large local company was convinced that that was the best doctor for him because his uncle, buddies, whoever had told him so. But when you think about how us as American consumers of healthcare make decisions, it makes sense why he thought that person was good, right? So walk us through like how medical management intervenes in a case like that, how you get this data, how you use it to steer employees to better care. Because guys, it's not all about cost. It's not. There's actually a quality and an access conversation that needs to be had too.
Well, you know the dirty little secret that I keep telling people, shh, don't tell my competitors because they're not smart enough to figure out a 5-step
They won't
process.
do it anyway.
Right. Or worse, they'll say they do it and then not actually deliver, which, that's a whole nother story.
No
But
kidding.
if you get the right patient into the right care at the right time, in the right place, the vast majority of the time, right price will be the natural consequence. That's what fee-for-service healthcare is. Right? Doctor just good enough has higher infections, higher readmissions. You spend a lot more for that than if you go to Doctor Great. So the opposite end is Doctor Death, and you're going to spend a lot of money and have a bad outcome, right? So what we want to do is it the right care? Now, here's the challenge. We've got carriers that have automated denials so that if a request comes in and this is the code, deny it. Period. Point blank. They're not looking at any of the clinical. They're just across the board, we're going to deny this.
And
right?
Are you speaking about like carriers like Blue Cross, United, Cigna, Aetna, where they've automated with AI these prior authorization denials?
Yes.
And do the medical management teams at these carriers handle the prior auths, or is it the TPAs that are handling it?
It depends. It depends on what the procedure or service is.
Okay.
There may not be a human touching it at all.
Wow.
Right? Think about that.
Yeah, no, there was a lawsuit because one of the carriers, I can't remember which one, but there was like hundreds of thousands of just auto-denied claims. This was a couple years ago, but it was like a new AI algorithm and it didn't work. It did, depending on how it was set up, because the way that whole lawsuit actually came to fruition is they had an internal medical director whistleblower who said nobody has ever looked at these cases. Wow.
The computer denied these.
Wow.
Right? Talk about totally being unacceptable. But the other problem is everybody is pushing back or frustrated with or complaining about pre-cert and prior auth and that kind of stuff. The flip side of that is you have to remember, some of us have enough gray hair and are old enough to remember why that came to be. And it's because there was so much fraud, waste, abuse. There were all of these things that were being processed as claims that were like so far out of the lines, like we're going to cut off his elbow because his ear hurts kind of stuff, that somebody had to step in and say, whoa, 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 whoa. MCG, the evidence-based clinical criteria, has been around for almost 30 years. We know the science.
Right.
The problem is Americans don't like science. We also don't like math. So when you talk about using science to derive quality of care, when you talk about math to do objective quality scores of facilities and physicians, Americans don't want to hear anything about that. And this is such an emotional issue.
Yeah. But think about, like, I remember we had this case with you too. A patient was being prescribed a cancer drug and they didn't have cancer. And your team caught it. And it was a really expensive drug too. So it's absolutely wild to me. So obviously we have large carriers or internal TPAs auto-adjudicating claims. So how often are you the prior auth kind of pre-cert process versus like when is a TPA handling that?
With the majority of the customers that we work with, well over 50%, we're doing the pre-certification.
Okay.
There are two variables where we would not be doing the pre-certification. Obviously, if the group is fully insured and they just want an advocacy bolt-on, opt-in, we'll do some outreach, but it's like barely dipping your toe in the water.
Right.
Right? Let's just start making this available. And quite frankly, if you get into financial trouble and you start looking at, are people actually using this? Are they not using this? And they're probably not using it because you've not done a good job as an employer of promoting it and
Right.
keeping it in front of people. And it's easy to get rid of,
Yeah.
right? So it's not my favorite product. I love helping anybody I can help.
Yeah.
But from a business standpoint, there's no ROI.
So ideal situation then, like you're working with a self-funded employer usually. So HR, CFOs, anybody listening that doesn't really understand the difference between fully insured, level funded, self-funded, literally the same four components of the plan exists, and medical management is in every single one. It's just, it has different maybe incentives in all the functions of the plan have different incentives when you're talking about fully insured versus self-funded plan. Fully insured, you're paying the same kind of level premium every single month. You have absolutely no chance of getting any claims back in return, usually limited data, limited control, limited customization. We get into level funded. It's essentially a self-funded plan. The only difference is you're level funding it, generally meaning you're paying the same premium or the same premium equivalents on each employee every single month. You might have a chance at 50%, maybe more of a claims reimbursement. Self-funded, you're usually paying claims as they're incurred, and you are literally custom designing your health plan, which is what our specialty is, taking employers from fully insured to self-funded. So let's talk then, Nurse Deb, about how your program works in a true custom arrangement.
Yeah, it works however you want it to work. That's the beauty of it.
Isn't that nice?
Now,
imagine.
Right? Imagine that. Now, I'll come along and coach and advise and counsel you, right? But I'm just the consultant in that scenario. And I can tell you based on our experience. And the other thing is I have a master's in business with a minor in math and statistics. So if you want case studies, if you want to know performance reviews, if you want pro formas, we can do that. Right? We have that experience, we have that knowledge, and quite frankly, we have a big enough book of business, and we have enough people that are coming in and actuarially certifying and validating our results and our data and our outcomes. So, that's a little bit of a differentiator, I think, compared to what other people think of medical management.
Right.
It's more than just a nurse getting on the phone with a patient and, hi, how are you? And tell me what's been going on and let me be your sounding board.
Right.
It's actually navigating, it's actually applying those things and counseling the plan. Right?
Yeah, 100%.
But part of the challenge is, quite frankly, a lot of people will go self-funded without ever doing what I call the gut check and the heart check, right? Why are we doing this? What are the goals and objectives that we want to achieve? Are we doing this because we actually want to take better care of our people, or are we just doing this to save money? Right? And understanding those dynamics, like when I ask a new self-funded group, what is your per employee per year spend now? What do you want it to be? How quickly do you need to get there? How much noise are you willing to endure in the process? They look at me like I asked them, do they want green aliens or purple aliens to land in the backyard tonight? Right? Because they haven't even thought of those things yet.
There isn't really, for most employers listening, the thought that you could control your per employee per year cost on its at face value is like, I'm sorry, what? I remember when we first started working together, and I feel like I was part of the problem, to be perfectly honest, because when you're getting into these more innovative plan designs that it's not the same thing. So let me actually back up a little bit and tell employers how we've used AIM. So the way that we've implemented them into our programs is we put this in the guide, we're putting this in text message, it is call the nurse. If you have imaging, you have a surgery, you have anything serious going on, and there's a whole list of things that they can look at, but just call the nurse. And you essentially brand this entire program around call the nurse, and you make that kind of the pillar, the cornerstone, if you will, of your program. Call the nurse. And because a nurse is a trusted health professional, right? You're not calling the insurance company that wants to, has their own profits and motives, profit-driven motives. So it's call the nurse. When the employee calls the nurse, they're getting a lot of feedback on the care that they've received, then maybe the next best steps, maybe a second opinion. They're also going to be routed, Nurse Deb already said this, to the right place at the right time at the right price. They're looking at the actual insurance part of the decision making, what's in network, what's it going to cost, what provider, that kind of thing. But they're also looking at the quality of the provider. Is this the best clinical case right now? Is this what we should even be doing? Do you even need this care? So to her point earlier, they're fusing the healthcare financing and the healthcare delivery, which is the most important part of a successful program. Because without that, I mean, who's driving the bus? So when we've done that in the past, the way that we've incentivized employees to call the nurse, because this is really important, a lot of employees are like, well, I don't want to pick up the phone, right? I don't care about data. I don't care about this shit. Like, I don't want to do this work.
My doctor said.
Right, my doctor, exactly. And he has a billboard. You get them to do this by creating a guided plan option. And what that means is if an employee actually engages with the nurse, they get whatever it is, their MRI, even an outpatient surgery, you guys, at no cost. So that's how we've done it, and it's been very successful. And then, unfortunately, we did have one instance where like the employer had a change of leadership and we had to take this program out. And do you know how many employees were upset about it? This was a dealership client that we had. Yeah, they were all upset. And every single year, it's like, well, can we get that nurse option back where we can get free MRIs and free this? And, this leadership is a different story. But yeah, it works. What else would you add to that?
I would tell you that it's about the human component. So I get in trouble all the time for not talking enough about the technology, because at our heart, we are a technology company inside of the human element. So a lot of people are thinking that it's a tech play, right? Somebody should just be able to go to an app.
Right.
Well, I have people all the time who call in and go, I need a podiatrist. Oh, okay, sure. We can help you with that. What's going on? My knee's hurting. Did you mean an orthopedist? So if we let them just go self-direct and look for a podiatrist, we might be barking up the wrong tree. Or like a guy who literally this morning called us, so short of breath he could barely talk, who wanted to find a cardiologist.
You're like, ER, bro, you got to go.
Call 911. Do you need me to call them for you? Are you at home? Can I send them to your house? I mean,
wow.
So I don't think that this will, at least in the next 20 years, be a straight tech play.
Mm-hmm.
Now, your medical management vendor better have one heck of a hefty tech capability, especially if you want a custom plan. Because, it was really easy to take care of 8 groups, Chelsea.
No kidding. Right? I always think about
and let them be custom. But when you got 500 groups, that's a whole different story when you've got 2,000 groups. So you better have tech to support that customization.
I've always been curious about your scalability on the tech infrastructure because of just literally how custom, like you guys, the employees from our groups multiple groups would call Nurse Deb. They would know exactly like what group they're calling from, their exact plan design, the network if we had one. Like they knew everything right away. And it was very impressive. And then some of the things that happen in every good business and every good industry is a business does a good job. Everybody hears about them. They grow really fast because everybody wants to do business with them. And then they shit the bed because they either take on money or they try to grow too fast and there's no scalability or maintenance in that tech infrastructure. Not the case with you. You have, you're a great example for everybody. I think you should consult other vendors on this, actually.
You don't want to tell all them my secrets.
Yeah, right.
No, I'm kidding. But, right. Yeah. I mean, we went about a year ago from a very small team of dedicated programmers to a very large team of dedicated programmers. And a lot of that, too, has to do with our use of AI. So we've been doing claims data mining and predictive risk modeling for 18 years.
So tell me more about that. And so like to an employer, for example, or like HR listening to this, they're probably hearing the buzzwords in the industry, transparency, data, predictive analytics. What does that actually mean to them?
Let me give you an example. If you have ever been on an IV antibiotic called vancomycin, you have increased your risk of kidney damage. If you have been on 2 doses of vancomycin, you have doubled your risk of ending up on dialysis by the time you hit the age 65.
Yikes.
So, number one, do you think we want to be looking at medical necessity and appropriateness for that infusion and making sure that if you're getting it, it's really, you've got to get it, right? And number two, do you think that we could keep track of which patients are already had 2 doses and maybe outreach to them and talk about a kidney healthy diet and lifestyle? And do you have any other risk factors? Are you diabetic? Do you have high blood pressure? Right? We can do all of that through technology. And that's just a very, very basic, simple example.
Yeah.
We can take thousands of data points through medical artificial intelligence and tell you, Chelsea, there's a really high likelihood, like 90% plus chance, that next year you're going to have an ER visit. And here's where we see that risk factor coming from, right? Or we know because you're on these medicines and you're this age and you have these conditions that you're going to have a hospitalization. Let's get in front of that, right? You haven't had these preventative exams. That's simple stuff, right? So, but through medical artificial intelligence, we can predict risk.
Yes.
If you can predict it, if your nurses are able and willing to get on the phone and talk to people about it, and you've taught them Prochaska method, motivational interviewing, engagement strategies, if you've given them natural language processing artificial intelligence software that listens into every call, and when it hears the word suicide, it pops up and it alerts a manager to hop in and help with that call, right? So there's technology in the background that enables and supports and enhances. That's why I look like such a genius. I wish I was able to keep that all in my head. I really do.
No, you
But it's
don't,
the
because then it's not
technology.
repeatable, right?
Right.
You're
It's not
totally the
scalable.
bottleneck, and you're not. Your aim, I mean, just the growth that I've seen in the last 6-7 years, it's incredible. It's totally incredible. So you've already been using the predictive AI that everybody's talking about now, which is really cool. Tell me about some of the other like important data points that you're sourcing and your nurses are using when they're helping employees make decisions about their healthcare delivery.
Well, obviously, evidence-based care guidelines, I mentioned MCG earlier, everything starts there. So you first have to triage the patient. You have to understand the clinical situation. You have to understand, is that medically necessary and appropriate? Are there alternative options? Is it the right level of care? All of that clinical stuff.
Yeah.
And quite frankly, there are companies that do really good work in that area, right? We're not the only ones. There are some people that are really good at using MCG. MCG super users is kind of the industry terminology for that. But on the other side, you've got the whole claims data mining, predictive risk modeling, you've got natural language processing, artificial intelligence, you've got scripts and steps and all those things about how to talk to people, because there actually is a strategy to do that, especially when you're doing it telephonically and you can't always see them, right? But we license currently over 40 different quality and cost transparency tools.
Wow.
And this is the Wild West of our industry right
It
now.
is.
So do I love transparency? Absolutely, I love transparency. Do I love quality scoring? I love objective case mix adjusted severity risk indexed quality scores. There's a lot of quality scores out there that don't meet those parameters, right? And that's a whole nother, I shy away from those. But there's not currently, or maybe I should say not yet, a single Consumer Reports of Healthcare. And quite frankly, right now, I don't think that the vast majority of the general public could or would use it even if it was out there.
I totally agree with you. I keep seeing these posts on LinkedIn where everyone's like, insurance is going away and quality data and, price transparency is going to take over. And I'm like, so at Ethos Benefits, I think I've shared with you, we have a very strong sort of like internal advocacy. We do a lot for our clients in terms of we're texting employees constantly. We're helping them set appointments. Like we're doing a lot of stuff that most advisors and brokerages won't do because they don't think it's scalable. I have a whole argument against that. It's for another day. But like, I don't see people actually doing this on their own. I just don't. Even I don't want to do it on my own. And I understand it. right? Like,
especially when they're sick.
oh, 100%.
When they need it most,
yes,
right?
Yes.
Yeah.
And
You've got to give them that advocacy and that support to enable that and to lay it out for them on a silver platter, not to force them, right? I don't ever say you have to do this or you have to do that, or, I'm not making the decision. I'm there to give them the information, the resources, the support, the guidance,
the data-driven information.
Yeah, that with that emotion kind of set aside, like I have no skin in the game.
Right.
I'm just here to give you the best access to data and the most meaningful. And if you ask me, what would you do? I'll tell you, and it's going to be driven from the data, right? And I also followed up with, but I'm not you,
100%.
right? I would probably go get the blood transfusion. You're a Jehovah's Witness. You're probably not going to do that, right? So, the other part of it is this evidence-based medicine concept eliminates all those social disparities of healthcare, right? Because the evidence doesn't care what color you are, what gender you are, what your sexual orientation is. None of that matters.
Do you feel like the data is fair, though, for those demographics? Like, did it capture them? Because I know that in itself, in terms of like healthcare reporting, right? Like even women, we weren't included in studies until what year? Like 20 years ago? I'm just kidding, but you know what I mean.
Yeah. From an evidence-based standpoint, I do believe that it's solid.
Okay.
From a quality score standpoint, I still think we've got a long ways to go to get there. That's very much in its infancy, right?
Interesting.
And so, there's different depths of accuracy of the data, right? If you're pulling just from CMS, then you're only getting doctors who are accepting $1 or more in payment from Medicare. What about all those doctors that don't treat Medicare patients? Pediatricians would be a perfect example, right? You can't use a CMS derived data set for pediatricians. Can't really use it much for OBGYN either, quite frankly. Then you go on to commercial claims clearinghouses. You can access those. That's great. But what about the Dr. Keith Smiths of the world that are cash pay only? Their data doesn't exist in either of those. So there is this whole idea that, some of this is still in its infancy. I think, stacking the deck in the patient's favor using the information we have is better than just saying, well, it's too much in its infancy. We're not going to do anything. That's what got us here.
100%.
Right? This healthcare crisis started in the 1960s. Here we are, right? We're either going to fix it or we're not. We got to take steps.
And there are,
that part of it.
I know I've been a little negative in terms of like, so sometimes and I know we've talked about this before, but sometimes I'm just like, why? I've had some conversations with employers recently where it's like, we go through this entire process of education on this new way of thinking. They're super excited. They go back to talk to their current incumbent broker about it. And then they come back with, well, we don't want to lose our discount rates with our network. Right. So it's like, and then just
if you will actually manage utilization, you can more than offset the loss. You could pay full retail, manage your utilization, get your people the best care from the best doctors, and you would still cut your costs by 20 to 50%.
Exactly. Never mind like reference-based pricing, which would be more significant.
We have reference-based pricing plans that are performing at $2,000 per employee per year.
Yeah.
Medical and pharmacy claims combined.
That's incredible. So to give everybody reference, like the Kaiser Family Foundation puts out a lot of these stats every year for the per employee per year costs. I want to say the average is somewhere between 15 and 16,000 this year, right?
Yeah.
2,000. That's insane. Wow. So
if you really give a shit and you want to do something about it, you can.
100%.
Employers across the country have been and are, and there's no reason not to other than you lack the intestinal fortitude to do it.
Yes, which is another way of saying balls. So no, and it's always fun to chat with people like you because I know you've been in the trenches a hell of a lot longer than I have. You've fought way bigger fights than I have. And it's just so inspiring to see you every single day, like continuing, no matter what's coming at you, just to keep going and fighting the good fight because it takes so many of us. And, it's funny, like, it's literally the way I think about it is like, it's one employer at a time. It's just one piece of education. Like maybe this is the podcast where it clicks for an employer that's listening. And maybe they've listened to our shit for 5 years, but they're like, oh, incentivizing the plan design, and my patients get better care at the right time at the right price, and my claims go down, like maybe this is the thing that ignites change, right? So I think we just got to keep talking. We got to keep talking about it. We got to keep showing up even on the hard days, because we are doing important work, and one employer at a time will change the American healthcare system. So we need to wrap up, but I want you to tell me, do you have anything that you'd like to say to our employers that are out there listening?
Yeah, well, the government's not going to rescue you.
When have they?
Right. So let's just get over that delusion.
That's a good point.
The other part of it is, I get it, math and science are hard, and I get it that they're not the best, loved subjects in the US. The other part of it too is that we have to do something. It may not be perfect. We could get it to perfect if we can adopt and engage and move the ball forward. It's really boils down to, do you give a shit enough or not? Are you willing to take the risk or not? And I would say, we've been saying, do you want to wait until your employees sue you or not? you know, so I mean, there's a lot of, I understand the trepidation. I understand it's not your fault that you've been lied to,
Right.
and that were scammed by a abusive, misaligned, kind of system. But now that and you got to do something about it. And anybody who's encountered any kind of health event lately is probably at the point of pulling their hair out. It's just, I think the fury that we have seen, and it was one thing when people were out in the streets with signs, Medicare for all, and protesting. It's another when people start getting killed. And so I, you know, we have to do something. We're at the point where we have to. We can't sit back any longer. So
All the
that's what I would
forces.
say to
Well,
employers.
I love it. And I think that message is perfect, and it's a great way to end the show. It just seems like all the forces, right? Like legislative, political, human, like economic, all of it are coming together at this interesting time, and it's peaking. So I do agree with the message that, once you have a responsibility to do something with it. And it doesn't have to be a big something. It could be just a tiny step in the right direction. Actually, that's a good question for you. Let's end on this. Just kidding. We weren't done. If you were, for the employers listening, if they could take just one tiny little step in the right direction, what do you think that step would be, in your opinion?
Ooh, it depends on the employer, it depends on the culture, it depends on the goals and objectives. I mean, selfishly, what I want to say is bolt on a nurse navigation service, right? In reality, that may not be the right answer. It might be getting a fiduciary PBM. It might be just having the cojones to take the carrier logo off your card and go to an independent TPA. But for every group, I think that's going to be different. But you have to do something. You can't just stay where you're at and expect things to get better. They're not. I mean, and if you think the government's coming to your rescue, you're so delusional that I should probably help you get admitted somewhere.
Do you need help?
Right? Are you safe? Wink.
Are you okay? Blink twice.
Right. Here's a red marker to, ask for the angel shot,
Right?
whatever it is, right? That's what we need to come up with, the angel shot. Yeah, right.
I don't know if
There
you can
go.
see that. It says help.
Help. But I mean, just like transparency legislation, I love it. Oh my God, finally, hospitals are required to publish their data. Bullshit. They ain't publishing it. The penalty is so small that, I mean, they would rather pay the penalty than publish the data. And we're not even talking about objective quality scores. Like, the Scarlet A, we all had to read that book in high school, right? Or those of us of a certain age had to read it in high school anyway. I want a scarlet letter on a lab coat, right? You see my logo here? I want this to be A, B, C, D, or F. And if it's F, I want it to be like this big and bright red.
Yeah.
So that when you walk into the hospital floor to take care of my mom or my dad,
Yeah, I'm
I
like,
go,
hell no.
whoa, buddy.
You're an F.
Back off, right?
That has two meanings. You failed and something else.
Right.
Wow.
Yeah. So,
I love that.
I mean, we can enact all the legislation that we want, but it's a barking dog with no teeth. So until you get down to the point of Bobby is sick, Sally has breast cancer, Mary's husband needs spine surgery, and you as an employer go, I love these people. I want to take good care of them. And if you're in Silicon Valley and you want to take good care of them and you don't care what it costs, fabulous. I will tell you one story. I had an employer who said to me, Deb, if you can just come in and keep our costs flat for a couple of years, that would be wonderful. They were a municipality, right? And they were, just keep us flat for a couple of years instead of these increases that we keep getting. We will love you forever if you can just keep us flat. Well, I have to tell you, I failed. I couldn't help myself.
I had to save them money.
I couldn't help it. We dropped their cost about 5% the first year without really trying, because you can't let a patient go to a quack cardiologist and still sleep at night, right? So if you just care enough about your people to give them some hope, some help, some resource, it's going to have a positive effect.
Yeah, ROI will be there. And more importantly, you're just doing the right thing for the humans that serve your company every single day.
That's right.
100%. Well, this has been so fun. Where can our listeners find you?
Oh, aim-m.com. Our website, of course, LinkedIn, right? Follow me there. Call, text, carrier pigeon, smoke
call
signals,
the nurse.
just
smoke
call
signal.
the nurse.
You can write help on the back of your page and she'll be to the rescue. Well, thank you so much, Nurse Deb. I'm so happy that that we actually got to do this. I know I've been thinking about having you on the show for a while, so this is probably one of my favorite episodes, and I hope you have an amazing day. Thanks for joining us.